We're going to talk about some of the basics today about nuclear cardiology. And so let's see if this thing really works. It does work. It won't run out either. It won't run out. It'll keep going the whole time. Amazing. Okay. So first of all, let's talk about what we don't image. We don't image alpha particles, which are helium nuclei, which are big particles. Because these can be stopped by a sheet of paper, actually tissue paper. They're deadly. They have very bad biological activity, but they can be stopped very easily. We don't image beta particles, which are electrons, okay? Because beta particles can be stopped by a piece of paper, not tissue paper, but simply a piece of paper. So we have to image gamma radiation, okay? Because gamma radiation can only be stopped by concrete and lead. And if we're going to inject somebody with a radio tracer, we have to make sure it gets outside the body to get to the detector to be able to image it. So that's what we have to do. And of course, when we do single photon tomography, which is typically what we do here, we use radio tracers with gamma energies anywhere from 72 to 140 kV. When we do positron emission tomography, they're all 511 kV, and we'll talk a little bit about that. But that is the typical annihilation photon. It's 511 kV in energy of a positron. And in comparison, CT is anywhere from 70 to 140 kV, depending on body size and weight. Okay. It's important to understand the biological effects of radiation as well. And when we think about radiation, we think about several things. We think about equivalent biologic radiation dose, and that's based on the radiation emission that's being done. So if you look at alpha particles, as I said, even though they can be stopped by a piece of tissue paper, they have 20 times the biologic hazardous effect as compared to, let's say, a beta particle or a gamma ray, okay? And that's because they ionize things about 20 more times than those other particles. And if you look at beta and gamma, which are electrons and gamma radiation and photons, that only is a factor of 1. So basically, your equivalent dose is not at all affected by, or your dose is not affected at all by is not changed based on if you get beta or gamma, because it's a factor of 1. Then we talk about effective dose. Effective dose is actually the effects on tissue itself. It depends on tissue sensitivity. So all different tissues have different biologic sensitivity to radiation. And of course, when we think about total dosimetry in patients, we actually add up what the relative amount of radiopharmaceutical goes to different organs of the body and what the biologic tissue is that's accumulating the radiopharmaceutical to determine the absolute effective radiation dose. So those are things just to keep in mind when you're thinking about doing nuclear imaging. Now, what do we image? What we actually do image is we image something called the photoelectric effect, and we image something called Compton scattering. Now, photoelectric effect is when a photon goes in and actually hits an electron and knocks that electron out as a photoelectron. You see actually a scintillation, okay? And the photon is absorbed. This is gone. All what you're seeing then is the photoelectric effect in terms of the photoelectron going out. And then, of course, another electron falls down to replace that in a lower shell, from a higher shell to a lower shell. We also get this thing called Compton scattering. Compton scattering is when a photon goes in there and it kind of interacts with the electron, but it really doesn't kick it out. It just loses some of its energy, and in the process of hitting or interacting with the electron and losing some of its energy, it also is scattered at an angle, okay? Well, these are the kind of photons which we really don't like, because scattered photons, as we'll show you, can really affect the spatial resolution of the imaging acquisition that we're doing, okay? And then we have this thing called pair production. Now, pair production is not something we see in the body. Pair production is actually how we produce positrons. And positron emitting agents that we use in PET are the ones that are, when they hit an electron, they cause an annihilation event, which then gives off a 511 kV amount of energy in 180-degree opposite directions. Okay, and that is what is measured when you do PET imaging by a detector. So this is all in tissue, both of these things. When we look at pair production, that's not done in tissue. That's in order to actually create the positron emitter. And then positron interactions occur in tissue. So this is in the tissue and in the crystal. Now, when we think about pair production, this is what I was talking about. You have an incident photon coming in here. You get a negative electron and a positive electron, or a positron. And then when you inject these things into patients, that's when you get an annihilation effect. And depending on the distance from where the positron is emitted and where it's annihilated will determine actually partially the spatial resolution of the radio tracer, of the PET imaging procedure you're performing. So you might imagine that PET agents that have high energy, they will penetrate further before getting annihilated. And therefore, they will have lower spatial resolution. So actually, it turns out that the lower energy PET agents like FTG have the best spatial resolution. And rubidium, which has the highest energy, actually has the worst resolution because it travels through tissue further before it's actually annihilated and detected. So even though it's emitted here, you only pick it up here. So that kills your spatial resolution, okay? So rubidium is not such a great agent. And there are actually FTG agents that are being developed now, one being fluoropyridaz, which I think is going to have very promising effects. This just goes to show you, F18, this is an MeV, but it's 635 keV. Rubidium is 3,350 keV when it's emitted. Okay, so it's very high energy, travels very far, but unfortunately that is not good because it really affects your spatial resolution. Okay, these is also what we do not image. Okay, so these are kind of interesting things because ionization radiation or characteristic X-rays we do not image. We do image these actually in CT, and in fact in CT we actually image characteristic X-rays to a lesser extent, but primarily I can never even pronounce this word, Bremslung or whatever, okay? But it's called breaking X-rays. It's German. I'm not German. I don't speak German very well. But anyway, breaking X-rays, and this is when the electrons come close to the nucleus, and but they don't interact in any other way, and they give off X-ray emissions. And these can vary tremendously in terms of the wavelengths. Okay. So in CT, we actually do a lot of this, but this is not nuclear. Nuclear, we don't measure characteristic X-rays, which are when the actual ionization occurs and the electron is emitted from the nucleus, and we don't measure breaking X-rays either. But we do measure ionization events, which lead to scintillations from the photoelectrons that are emitted. Okay. Okay. This is just an example of what happens with an electron. You have to have conservation of energy. So you have photons going in, they knock out an electron, and that has to then, when that electron is freed, it gives off a certain amount of energy, and when that energy, there has to be conservation of energy between the photon that's coming in and the electron that's being emitted. When you have scatter, which is Compton scattering, you lose some of that energy. So you have an incoming photon, it interacts with an electron in the atomic nucleus, okay? It's deflected, and in that deflection it also loses energy and is scattered to a certain degree. This scattering is very, very bad in nuclear cardiology because you can imagine that in the body, there's a lot of different tissues and a lot of different densities, right? And there's going to be scattering of photons, not absorption of photons like you get with photoelectric effect, but scattering of photons. And it turns out that the isotopes that had the lower energy, like thallium, for instance, okay, they actually can deflect 78 degrees without having much reduction in their energy. So what does that mean? That means when we think about imaging, we usually put the we put the peak of the camera at like 72 keV, and we use plus or minus 10% on each side of the photo peak to be able to detect a photon. Well, what that means is when you use an agent like thallium, you're going to detect a lot of scattered photons. And that's going to really affect your spatial resolution, okay? It turns out with technetium, which is a higher energy photon, if you deflect greater than 54 degrees, okay, you actually are within that 10%, but if you deflect more than that, you're outside that 10% of loss of energy, so you don't accept that photon, and we don't accept that photon in imaging, okay? So thallium is actually the worst agent. Thallium is terrible. Not only does it scatter all over the place, but when you scatter it, you actually collect most of those scattered photons, which is something we don't want to do, okay? So that's why, generally speaking, today we use just technetium 99M. Notice F18. F18 only has to scatter 27 degrees, and it loses enough energy where you would not accept that as a photon you'd want to use for your image. So that's why I think these kind of agents are actually going to be very, very helpful in the future. And not only can you Compton scatter, but it turns out you can Compton scatter many, many, many times in the body, okay? So you have a photon, let's say you injected the patient with technetium or thallium, let's say. The photon is emitted in the patient. It gets scattered here, it gets scattered here, it gets scattered here, and maybe it still gets scattered to a point where it hasn't lost enough energy where it can be still detected by the system. So you have the incident photon here, and you have the actual detection here, and you can see the distance, and that's why that really hampers the spatial resolution. Okay, so that's something to keep in mind in terms of the radiopharmaceuticals and this whole terrible concept of Compton scattering. Now, when you inject a radiopharmaceutical into a patient, and this is just a liver, I don't know why I didn't have one of a heart. I should have had one of a heart, I suppose. We don't do liver scanning. But anyway, same principle. A photon is emitted. If it gets outside the body without being scattered here, there, and everywhere, or being absorbed through photoelectric effect, it will ultimately go through a collimator, which directs the photons, only gets those, hopefully gets most of the photons that are actually parallel to where the photon is being emitted, and then it will hit a crystal. And this is usually a sodium iodide crystal. We now have CZT systems, CZT crystals as well. We'll talk a little bit about those. But this particular crystal, sodium iodide, will then cause this photon going in, hitting the crystal, will cause a photoelectric effect, will cause a scintillation, and that scintillation through the use of PM tubes, photomultiplier tubes, will multiply that light that's being emitted, and then that will be detected by a grid in terms of producing a picture. Okay, so the X, Y, and Z axis are then identified. Okay? Just to go over this a little bit further, we talked about SPECT in terms of the types of radiopharmaceuticals we use, and PET and CT. I just want to emphasize the fact that just like in nuclear, here we have a photon coming out. What we really like to do, since we're looking at emission imaging with nuclear, is that we really want to get the photons out of the body. Okay, we don't want them attenuated in the body. We want to get as much of the photons out as possible intact, passing through. Because that's the other interaction. I talked about photoelectric effect. I talked about scatter. The other interaction that photons have in the body are nothing. They just pass through and hit the camera. Okay? So there's three types of interactions. So that's the most important interaction for us, if we can get away with it, is to have the photon emitted in the body and just simply pass through the body and hit the detector camera head and be accepted. Okay? Unfortunately, we do have to deal with scatter and attenuation of photons. Now, Just as an opposite, I'll say just a little bit about CT. CT is just the direct opposite. In CT, since it's a transmission image, we're banking on attenuation. We have to have attenuation because every single tissue in the body has different attenuation characteristics. Okay? So the only way we can get an image with CT is to actually see attenuation. If we don't see any, if all the photons go through, we have no picture. Okay? That's completely opposite of nuclear, where we don't want any attenuation. We want everything to go through so we can get a picture. Okay? But it's based on all of these same principles that are very, very important in both of these imaging techniques. The other thing to keep in mind when you think about the radio tracers that we use is where they sit in terms of photoelectric effect versus Compton scattering effect. So this is just a nice little grid. It's showing this is where Compton scattering happens. So this is in MeVs. So right here is the 140, is the 72 keV of thallium. And you can see in soft tissue, what you see is a combination of photoelectric effect and scatter, okay, when you have thallium, okay? When you use technetium, which is this, is 140 keV, it turns out that, again, you do get some Compton scattering, but you get more photoelectric effect than you do Compton scattering. It turns out in a sodium iodide crystal, which is this, okay, you get all photoelectric effect, which is what you want. Because by that photon hitting the crystal and getting a photoelectric effect, you get a scintillation, which you then can accept as an event, which can be multiplied and used to create your image. Okay, so it's important to look at these events. Of course, lead, because it's so dense, okay, all of these things, no matter which one, whether you use the 511 keV of PET or the 140 keV of technetium or the 72 keV of thallium, all of these events in lead are photoelectric effects. Photons are stopped, dead in their tracks, okay, with lead. Something to keep in mind. I don't know if you still have bomb shelters or all, you need to have lead, you know. All right, so the other thing to keep in mind is that photon attenuation is basically derived by three things. It's determined by photon energy, because even if you have very, very high energy, even lead won't stop it. Material density, so thick lead is better than thin lead. And soft tissue is worse than lead in terms of getting things through. And material thickness, so thick lead is better than thin lead, right? Okay. So once these things get outside the body, then we have to make sure we get acceptable photons, okay? So we have this thing called a collimator. And all it is rows of lead spikes, basically, that covers the sodium iodide crystal. So you can imagine that if you have an X-ray source here and a photon is coming out, we want to accept photons that are fairly parallel to these lead septi, okay? So this would be accepted. This photon would not be accepted. It would be absorbed by the lead. This would be accepted. This would not be accepted. So you can see that the collimator kind of determines which photons are actually going to get through. And it turns out that in nuclear cardiology, over 99% of photons actually never reach the surface of the camera, okay? Because of all of these different things, either photon attenuation in the body or the lead collimator stopping things from getting through. It also turns out that this has a lot to do with resolution, and it's very important to know about what full width half maximum really is in terms of looking at spread function. If you have a point source here, okay, you're going to get a spread of what that image would look like. So if you had a point source, okay, what that point source would actually look like would actually be this width. This is the full width half maximum. So it would not be just a single point. It would be a something wider than that, okay? And that's determined by the full width half maximum. And that has important implications, because if you look at something like this, let's say you have a photon being emitted here and a photon being emitted here. Well, if these are 2 points in space, you can see that you would be able to discern this point from this point because the full width half maximums don't overlap. They don't overlap. So even though this point source would be broad due to the spatial resolution, you'd still be able to separate this point from this point. But imagine this scenario where you now have closer points. You have a point here and a point here. And now if you look at the full width half maximums, they overlap. So there's no way you would be able to determine that there's 2 separate points. You would say they're 1 point. Okay? So that's why it's very important to use these kind of concepts in terms of your spatial resolution, because it determines in how well you're able to discern single point sources in space. And the only way you can do that is to improve resolution, and the resolution is going to be determined by the full width half maximum, which is right halfway between the top and the bottom of this point spread. Okay? That makes sense? All right. The collimator tends to be the best way to determine the resolution of the system. And the collimation is going to be, and the resolution is going to be determined by the diameter and length of the collimator holes and the distance of the source from the face of the collimator. Now, it also turns out that the sensitivity, which is the amount of photons accepted, are also going to be determined mainly by the collimator in terms of how many photons can actually strike the crystal. Okay? So these are some parameters that are well accepted and well known. So if you increase the hole diameter, you obviously increase the sensitivity because more and more photons from different places can get through, but you decrease the resolution because some of those photons are from all over the place instead of being where they should be in a direct parallel line with the collimator. Okay? However, if you decrease hole diameter, you improve resolution, but you decrease sensitivity. So everything's a trade-off. If you increase the whole length of those lead septi in the collimator, that makes it more difficult for a photon to get through. Otherwise, before it being absorbed by either side, those lead barriers, right? So you'll improve resolution, but since less photons get through, you decrease sensitivity. Okay? So depending on what kind of collimator you have, whether you have if you have small holes and you have, and you have the holes are long, you'll have better resolution. If the holes are wide and short, you'll have less resolution. And so we look at the whole issue of where sensitivity, the counts per minute per microcurie, versus the resolution sit. And so there are different types of collimators. There are ultra high resolution, where you accept very, very few counts, but you have like very good resolution, like 4 millimeters. Okay? And then you have these, which are very high sensitivity collimators, which have very wide holes and they're very short holes, which accept a whole lot of photons, but unfortunately, it leads to very, very poor spatial resolution. Now, in nuclear cardiology, we kind of take a compromise. We use something called a high-resolution collimator, which gives us enough counts, but also keeps our resolution reasonable. So when you think about it, overall, our resolution is about 7 millimeters, 7 to 8 millimeters in terms of what we can resolve. 2-point sources separated by 7 millimeters, those can be resolved. Anything closer than that is going to look like a blob instead of 2 points. Okay? It also turns out that, and I tell this to the techs all the time because this is very important. It's very important to make sure that the camera is as close to the patient as possible. And you can see that illustrated here because here you have a point source, and here you have the collimator and the camera, and this is the point spread function. And you can see that's pretty narrow, so that's pretty good resolution. But let's take that, so this is using a low energy all-purpose collimator. Now let's move that point source further out. Now look at the point spread function. So you've degraded your spatial resolution by having the point source, the patient, further away from the camera face, okay? Nothing else has changed. You haven't changed the collimator. You haven't changed the millicuries that you're administering. You haven't done anything different. All you've done is move the patient further apart. And as you move them further away from the camera face, you degrade the spatial resolution. Look what happens when you use a high-resolution collimator, which has thinner septi and longer bores. Now, even if you have that patient at the same distance, now look what happens to your spatial resolution. Okay? Much better. But the sensitivity goes down because you accept less photons. Okay? So you have to image longer to get all the counts you need, because without counts you don't have an image. Okay? But you do improve spatial resolution. And that's one of the reasons why we use high-resolution collimation and why we want to get the patient as close as can be to the gamma camera. So again, for all types of collimation, resolution degrades as the object moves away from the camera face. Okay? And this is just, again, another way of illustrating this. You can see this is the point spread function for here and for here. And this is the heart here, and you can see the photons come out in rays, right? And this keeps going out further and further. And this is the sweet spot right here. These are the rays that are going to be hit by the collimator. But notice that the ones that are accepted here close in are going to be much fewer rays as compared to when the patient moves out here, where there are many larger rays, okay? And that's why the point spread function is so much wider here than here, and why the resolution goes down when you have the patient further away from the camera. Okay, very, very important concepts. Okay, so the other issues is the detector itself. Obviously, we use sodium iodide crystals in most of our cameras. They're light detectors, okay? And what we do also in this is that we have a voltage discriminator because we want to be able to identify, if we're giving technetium, which has 140 kV, we want to be able to say, look, we're only going to accept photons that are 140 kV into our picture, even though some others may have gotten through the collimator. Only those that are 140 kV with some window, and usually a 10% window on each side of the kV photo peak. There is a trade-off, as you can see, in terms of the thickness of the crystal and the number of photons that are detected, that you get to a point where you get to a sweet spot, which is right here, where you get maximum detection, both in terms of this is a higher kV. This is our 140 kV technetium. After you start thickening the face of the camera or the crystal too much, you get no greater improvement. Okay? So there's no point in just having thicker and thicker crystals. So there is an optimal thickness, and it's also to remember that you don't want crystals that are too thin, because if the material is too thin, remember I told you that the way that you get photons to pass through material, if it's a certain thickness, if it's thinner, it will pass through easier. It will not interact with the substance, right, with the material. So if you have too thin a crystal, all your photons will simply pass through and you'll never get a scintillation. You'll never get a photoelectric effect. So there's an optimal thickness of the crystal that has to be considered. The other thing that you have to consider, this is that pulse height analysis that we talk about. We really want to just accept photons that, for instance, for technetium, that are 140 kV. But we have some window on both sides that we'll accept. Now you have to understand there's a tremendous spectrum here, because there's all types of photons that get accepted into the crystal. There are backscattered photons, there are Compton scattered photons, and there are many, as I showed you, Compton scattering can occur in many different places in the body. You can have first order Compton scattering and second order and third order. So many different types. And that's reflected here in this curve. If you look at the various energies of, let's say, 140 kV photon from technetium, by the time it gets to the crystal, you can see all the different scattering that's happened here. So with our pulse height analyzer, we try to just emphasize those photons that sit around the 140 kV photon of technetium, and try to and don't accept all of these other ones, which are going to do nothing but degrade our picture and also destroy our spatial resolution. Okay? Nowadays, we have some new crystals. Instead of sodium iodide crystals, there are several companies, Spectrum Dynamics. We have one of these. We have the GE Discovery, which is a CZT camera. CZT is nice because it directly produces electron current in response to gamma rays. You don't get scintillations anymore. You don't get light where you have to amplify the light. You simply, right off the bat, produce electron current. And these things are actually much more efficient. So if you look at the energy resolution, and again, this is looking at the pulse height analyzer, and you look at the amount of Compton scattering that you accept, you can see that the curves here are much tighter for CZT than they are for sodium iodide crystals. And what does that mean? That means that we have better spatial resolution when we do imaging with these kind of crystals than we do with sodium iodide. Okay? All right, so now we've got our photons. I'm just trying to take you through the whole scenario here. Now what are we going to do? Now we have to do something called back projection to get a picture. Okay, because we've gone, remember these gamma cameras, they go over 180 degrees over the body. Every 4 degrees you take a picture. So we get a picture here, we get a picture here, we get a picture here. It's almost like we look at someone in different views from different angulations. And all these have to be back projected on a grid. And incidentally, we do the exact same thing in CT. We get 180 degrees worth of data, different images from all different angles, and we back project that on a grid, filtered back projection. And then it's just a determination of what kind of filtering we use. Do we use a ramp filter, or do we use iterative reconstruction, etc.? Okay? This is just an example. If you just took one view of something, you would have no picture. If you have 2 views, you start to see a little bit of interaction where the points meet. You get 4 views, well, now things are starting to look better. 8 views, now you have an image. Okay, it's where all the intersections occur from all these different angulations. That's filtered back projection. It's absolutely critical in nuclear, and it's absolutely critical in CT. It's the premise by how we create 3-dimensional images. Okay? But then we get to the issue of filtering. Now we got to filter this data. Okay? We have all this, we have this raw data, we have it back projected, and it's very important to understand how filtering is performed, because all images contain both high and low frequency components. The high frequency components tend to be the edges. The low frequency components tend to be the uniform non-edge related areas where there's no change. So in a scan, it would be where you'd have a change in counts, a dramatic change in counts. Or where you didn't have a dramatic change in counts, right? That would be a low frequency. So it's just like a picture would be, okay? So here you got a nice image. I like this image. Remove very high frequency. Remove high to medium frequency. Now remove all but low frequencies. Well, now you don't have an image anymore because you have no definition. All your high frequency, all your edges have been, all your fine details, which are high frequency findings, have been removed, okay? So obviously in imaging, we have to find some compromise here in terms of what we utilize to make an image. How much filtering do we really need to do? Okay, the other thing you have to remember is that resolution or image resolution is always dependent on your pixel size. Okay, so this is an example. The more pixels you have, the better image resolution you can have. Now, that has nothing to do with the intrinsic spatial resolution of the camera. The spatial resolution of the camera is determined by the collimation and everything else, okay? But you can still improve your image resolution by having more pixels, okay? So here's a typical grid. You have 1200 by 800 pixels. Nice picture. This is 320 by 250. Now you have better definition of that particular image, right? This is 43 by 43. Now look, it's all degraded, okay? Because the pixels are bigger. Okay, so pixel size does also matter, and so we use 64 by 64 matrix in nuclear cardiology. Obviously in CT we use 512 by 512, which is somewhat optimal it gives us 0.5 millimeter pixel sizes. Obviously we're not trying to achieve in nuclear 0.5 millimeter pixel sizes, so we use our matrix is standard 64 by 64. But it shows you how pixel size can dramatically affect your image resolution for whatever spatial resolution you may have, okay? So again, it's always a question of how much to filter. We try to optimize that. It's somewhat subjective, and over the years we've learned what cutoff frequencies we like to use in terms of optimizing filtering, because we don't want to filter out a perfusion defect, and by the same token, we don't want such a granular image that we can't interpret it. So here's just an example. This is unfiltered, filtered back projection. This is just filtered back projection of an image. And this is applying different filter frequencies where you have some of the high frequencies taken out, more of the high frequencies taken out, and now most of the high frequencies taken out. And you can see how smoother this gets, right? But you can smooth away a perfusion defect if you overfilter, okay? The other concept is noise. Noise is very important, okay? And noise is basically the 1 over the square root of the number of counts. So the more counts you have, and that's why we try to get as many counts as we can, because the more counts you have, the less noise you have. Just an example. If you have 100 counts, okay, the square root of 100 is 10. So therefore, the noise to signal ratio would be 10%. You'd have a noise of 10, and you'd have a signal, which is the number of counts, as 100. That's 10%. Well, that's a lot of noise, 10% noise, okay? Now look what happens if you have 10,000 counts per pixel. The square root of 10,000 is 100. So now you have 100, which is this, divided by 10,000, you only have 1% noise, okay? So the more counts you have, the more counts you acquire, okay, the less noise you'll have. And incidentally, this also applies to CT in a big way. In terms of when we think about contrast to noise and signal to noise ratios, it's all based on the same premise. And noise is still calculated the same way. Instead in CT, instead of having counts, okay, we have MA. MA is what gives us our contrast, which gives us our contrast resolution, okay? So a little bit different, but same principle in both of those techniques. So, with higher kV photons, okay, we get less tissue absorption in the body. Therefore, we have less photoelectric effect. We also have less Compton scattering, and therefore we get better images overall. And we also get improved energy resolution with higher energy photons and improved spatial resolution. And again, I talked a little bit about some of the other issues that are important with spatial resolution. I'm going to go through this quickly because this is just what we typically do in terms of camera uniformity, which is very important. If the face of the camera isn't uniform in its acceptance of photons and its identification of photons, okay, then we will get a lot of abnormalities in the image itself. Okay, so we do these things called integral uniformity, and we analyze it on a grid. And we look at different pixel counts in different areas of the crystal surface, both with and without the collimator. And we look at this. This would be a very nice looking picture. This would be a very degraded looking picture. This is like over 10% difference in integral uniformity. So every day we do uniformity correction on the gamma cameras, okay, to ensure that we have uniformity so we can get good pictures, okay? And like I said, we can do intrinsic measurements which don't involve the collimator, as well as extrinsic, which involve the collimator and the crystal. Okay. Causes of non-uniformity can be many, and of course these all have to be considered when you're taking your images and doing your daily floods. Spatial resolution is, again, we generally measure that using bars and phantoms, and we look for able to discriminate between various lines, very similar to the line pairs that are used in CT to be able to discriminate between different lines in terms of your spatial resolution. And center of rotation is kind of a unique thing to nuclear because remember we have rotating gamma cameras, and if they're off center, when you do a back projection, you will get distortion. Okay, so here's an example where this is a relatively normal image, and this is where the center of rotation was positive 1.5 pixels. And this is where the center of rotation was off negative 1.5 pixels. You can see the distortion where you actually create perfusion abnormalities. So it's very important that center of rotation procedures be done, and that's one of the quality assurance issues that we do every day. In terms of looking at images, okay, it's always, now we're down to the physician level, okay? So it's very, very important that you always, and as you know, all of you, I tell you, you need to look at the raw data, you need to look at the raw data, and then after that, before you look at anything else, you need to look at the raw data, because you can get a lot from the raw data. Is there vertical motion, horizontal motion, by looking at the spin data? What is the distribution of the tracer? Is the infiltration of dose? Is there extra cardiac interference or contamination? Are there areas of abnormal uptake? We sometimes see breast mass and those kind of things. And the attenuation pattern, if there's diaphragmatic or breast attenuation, etc. You can see what happens with motion. Okay, this is with motion. You get these kind of artifacts here. This is motion corrected. You can see those artifacts go away. So artifacts can hide or create lesions, and they can decrease sensitivity, obviously, in your diagnostic accuracy. This is just an example of a case of a ramp filter artifact. And this is also x-axis motion. So this patient moved during the study acquisition, and there are two types of motion. There's y-axis where the patient is going up and down like this, and there's x-axis where the patient is going like this and this. And I think you can appreciate on this patient that it looks like he's got a lateral perfusion defect here before correction, and then this patient was actually re-imaged. And you can see that that's completely gone. So x-axis motion is something you should always look for. You should always look at the raw data to make sure that there isn't motion artifact. Breast attenuation is another thing that we commonly see, especially with our larger and larger patients that we see. It's usually anterior and anterolateral, but remember that breast attenuation can occur anywhere across any part of the heart, depending on where the breasts are positioned in any given patient. And it's also very important that when you do have a patient with breast attenuation, that when you do the stress images, that you do the rest images identically. Because if the breast positioning is different on one image versus the other, you'll get different results. This is just an example of a patient with varying breast positioning, where the breast was partially covering the heart in this stress image and completely covering the heart in the rest image. And it looked like the patient had an anterior perfusion defect, which filled in on rest imaging, and that was not the case at all. This was just, that look of ischemia was just due to the differential positioning of the breast. Another patient from our lab several years ago, where a patient came in through the ED and had different breast positioning. There's a mild anterior defect here, gone on the rest imaging, looks like ischemia. The patient actually ended up having a CT, which is completely normal, just from different breast positioning. So very important to image patients properly. Diaphragmatic attenuation, more common in males. It's more common in obese patients, and it usually infects the inferior and posterior walls, but it can also affect the lateral walls as well, depending on where the diaphragm sits. And you typically get this kind of reduction in counts in the inferior and infralateral walls. And this can be very contentious, but it's very important, again, to look at the raw data to see. The other thing is that subdiaphragmatic count activity can cause many, many different types of artifacts, from the liver, the spleen, the gut. You can get contribution of counts from scattered counts into the inferior wall from any of these organs, or you can obscure. John? Listen, I'll call you back in 10 minutes. I'm giving a lecture. All right, thanks. All right. So subdiaphragmatic count activity can hide perfusion abnormalities, or it can create perfusion abnormalities. This is an example where you see a lot of gut over the inferior wall of the heart. Well, no one could read whether this was actually a normal inferior wall or not, because you can't see the inferior wall. It's completely covered over by the gut, right? This is an example, though, of a RAM filter artifact where the gut is adjacent. The hot structure is adjacent to the inferior wall. So here now, you see, because of the way the RAM filter works, you see an inferior defect. And in cases like this, what we have to do is we have to use iterative reconstruction to avoid that. So with iterative reconstruction, you see the defect goes away. But this is very contentious, and that's one of the reasons why we try adamantly to get rid of gut when we're doing imaging, because it leads the reader, myself and Dr. Nabi and Dr. Chang, in deep trouble when we see these kind of subdiaphragmatic count activity, which can alter and create perfusion abnormalities that just are artifact and not real. Okay? So that's basically I was going to go into stress imaging. I guess I can talk a little bit we have about 10 minutes left, because that also is an important topic. But this is the basics behind all of imaging, from basically the radiopharmaceutical back down to the interpretation and artifacts that we see. Now, in terms of how we actually do these images, obviously we have to have a stressor agent. Exercise is always preferred. We do have other agents we can use. Regadenoson is used very commonly now because it's a semi-selective adenosine receptor agonist, the A2A receptor agonist, so it doesn't cause a lot of other side effects that adenosine and dipridamol did. Okay? The whole idea of using a stressor, and this is very, very important, is to create a flow disparity between normal regions and abnormal regions that are supplied by stenotic arteries. Okay? And that's also not only dependent on being able to create these flow disparities, but to have a radio tracer that is taken up according to blood flow, so you can maximize the count difference between a normal area and an abnormal area. And just to show you how this might work, okay, it's called myocardial perfusion reserve. So I always like to think about it as money in the bank. When you're at rest doing nothing, you can vasodilate your coronary arteries about 3 to 4-fold if you need to. So when you start walking around or start walking or jogging or doing all that, you're able to increase blood flow in the coronary bed, so you can actually jog and do things because you increase your flow based on your coronary flow reserve. And incidentally, that's based on adenosine production, because when you start walking and doing things, you break down ATP. That breaks down into ADP and AMP, and what's the final thing? Adenosine. And then adenosine is pooled in the microcirculation, and that causes the arterioles to vasodilate to bring more blood flow. So it's a very nice feedback loop that the body uses. Okay? So when we image people who have normal arteries, we expect the flow to increase dramatically. In people with stenosed arteries, we expect the flow to increase minimally, because they've already used a lot of that flow reserve at rest just to maintain resting flow. So they have very little left in the bank to buy anything else. Okay? So maybe they can increase flow maybe 2 times, or 1.5 times, but they certainly can't increase 3 to 4-fold like you would in normal areas. So just as a diagram here, 80% lesion, maybe you can increase flow 2-fold. Normal area, maybe you can increase flow 4-fold. This 2-fold disparity in terms of flow, and hopefully counts as well within the myocardium that are taken up with the radiopharmaceutical, you'll be able to see a difference in count ratios here on an image and call a perfusion defect. Make sense? Okay, and again, with different ways in which you do things, at baseline, your flow is about 1 milligram per kilogram per minute, milliliter per kilogram per minute of blood flow. As you go to exercise, it goes to 2. With adenosine, you get up to 4, and same thing with dipridamol. Okay? With regadenoson, it's about similar to exercise. And you can see that peak only lasts for as long as you really need it when you give the radio tracer, because it takes about 2 to 4 minutes for the radio tracer to clear the blood pool and have completed uptake by the myocardium. Okay? So 2.5 is actually very nice, and like I said, it's very similar to what you see with exercise. So that's the issue in terms of being able to see disparity in flow. But then you have the tracers themselves. Their upflow, unfortunately, is not linear to blood flow. Okay? So you take something like O15 water, which is a PET imaging agent. It absolutely is linear across all blood flows. So if blood flow increases 5-fold, you'll see 5 times as many counts, okay, with O15 water. Tebaroxine, which we don't use anymore, it's a tech agent, had the similar thing. Thallium, not too bad. It's pretty linear except at very high flows. N13 ammonia and rubidium, getting a little bit worse. Look at technesium. This is what we use every day, folks. Okay? I mean, you get above about 3, and you start to really level off. So if you get into these higher flows of 4 times and 5 times normal flow, you won't increase the counts in that area, in that normal area. And so there'll be less disparity between the normal and the abnormal regions. Okay? Here's an example. Here's what you would see with for instance, let me get this on here. This is with O15 water. So if you have a 2.5 increase in flow from rest to stress, you will identify that absolutely the same because of the linearity of the uptake of O15 water. But what happens with technesium or rubidium or some of these other agents? You may get a 2.4 flow increase in myocardial blood flow, but that's only reflected as maybe a 1 or 1.5 increase in actual counts. So you underestimate significantly the amount of the perfusion abnormality because of the underestimation of flow in the normal area. Okay? Now it turns out fluoropyridaz, which is a new agent, a PET agent, which is hopefully it's going to come out. It's in its second phase 3 study now. It is much better than all of these except for O15 water, and is very linear across all physiologic blood flows, and should end up actually being a very nice agent for further use. So again, you know, when we image patients, we try to use exercise as much as we can, remembering that adenosine is always at work when we exercise somebody. Adenosine obviously causes the vasodilation. When we use dipyridamole as a pharmacologic agent, we actually block the reuptake of adenosine into the cell so it's not neutralized, and that's why we get pharmacologic vasodilation. Dipyridamole works through adenosine. Regadenosine actually directly interacts with the receptor, the A2A receptor. Okay. Obviously, I'm not going to go through all of this, but we have different ways in which we give these different agents. Regadenosine is nice because it's all done as 1 minute, over a 1 minute period. Exercise is still preferred because of all the other information you get with exercise in terms of SC segment depression, symptoms, heart rate, recovery, etc., whether they have ECG changes, and it also clears the radio tracer. When you exercise, you reduce splanchnic blood flow, so you get less activity in the gut, which is very important for nuclear imaging. Okay? Pharmacologic agents are reserved for those who cannot exercise due to a non-cardiac reason. Okay? And so if you have a non-cardiac reason why you can't exercise maximally, you shouldn't be getting exercise. It should be a pharmacologic stress test. It's been shown very nicely, and this is a study from Gary Heller many years ago, where he took a series of patients who had clear-cut perfusion abnormalities on a maximal stress test, nuclear stress test. Then he brought them back a week later and did a submaximal, 70% of maximal predicted heart rate. And look at the size of the perfusion abnormality. In fact, some of these patients never even got perfusion defects. So it's very important that if someone can't do maximal exercise for some non-cardiac reason, that they get a pharmacologic stress test, not an exercise stress test. Okay? The other issues are in patients that have left bundle or pace rhythms, you can get septal abnormalities. And that's particularly true with exercise. As you can see in a study that we published many years ago, very little in the way of septal defects due to adenosine regadenoson, or even now, or dobutamine or regadenoson. So just things to keep in mind. If people have pacemakers or left bundle, they should really undergo pharmacologic stress, not exercise stress. Again, even with pharmacologic stress, however, we try to exercise people a little bit because we cut down splanchnic blood flow and therefore we get less count activity in the liver so as not to obscure the counts in the myocardium. Okay? Adenosine, there are some absolute contraindications, particularly people with ongoing wheezing. One of the contraindications or relative contraindications is coffee, because coffee interacts with the adenosine receptor. That's particularly if you're like me and you have a venti pike every morning at Starbucks, where you're getting, your 415 milligrams of caffeine. I don't ever go to McDonald's because McDonald's is, you might as well drink water. It's nothing in there, okay? But there are some data that if you just have a little sip or one small cup of coffee, like a McDonald's coffee, it really doesn't affect your overall perfusion results when using adenosine. And so, that's why we're a little bit lenient in people. If they have small little cups of coffee, we're not too concerned. Regadenoson is now used as the preferred stressor because of the advanced studies which showed absolute similarity to adenosine. And we have actually published the data using quantitative analysis showing identical perfusion defects in these populations as well. Regadenoson nicely can be used in people with COPD safely. There's been many trials showing that, and showing no adverse effects compared to placebo in terms of FEV1 with regadenoson versus placebo in patients with pre-existing lung disease, moderate to severe COPD, and mild to moderate asthma. Dobutamine we don't ever use anymore because there's really no issue. The only people that use dobutamine are the stress echo people. It's still their mainstay. So in terms of stressors, exercise stress, again, preferred. Pharmacologic stressors in patients who have contraindications or who have left bundle, etc., or cannot exercise maximally. Dobutamine, never, ever, hardly ever nowadays. And again, choosing a stressor is always going to be up to the individual, up to you, looking at the individual patient. So those are some of the caveats behind how we get images, how we stress people to identify images. And in further talks, we'll talk about actual beyond image acquisition, how we clinically use this information to treat our patients and manage them.